Welcome to pharmacology of respiratory tract infection or respiratory diseases or pharmacology of respiratory system by Dr. Mu'tasim Siddiq Muhammad Saleh, Associate Professor of Clinical Pharmacology, Faculty of Medicine, the University of Al-Imam Al-Mahdi, Kosti, Sudan. First of all, what are the respiratory diseases or diseases for respiratory tract infections or respiratory tract diseases? Bronchial asthma, coughing, allergic rhinitis, upper respiratory tract infection, upper respiratory tract allergic conditions, chronic obstructive pulmonary diseases, infections in general, bacterial, mycobacterium, tuberculosis, gram-positive, gram-negative infections, and viral infection and airborne poisons. These are usually diseases in the respiratory system. We will start with bronchial asthma. Asthma is allergic response uh, or inflammatory disease, recurrent episodes of attack, acute bronchoconstriction. These are the main symptoms: shortness of breath, chest tightness, wheezing, rapid respiration, coughing, cyanosis. So, in case of asthma, this is the wall of bronchioles. So, congested, narrowing, and mucus thickening or thickened air wall. Causes of bronchial asthma, as you know, inflammation can uh, infections. It is inflammatory disease, infections, endothelial conditions, or emotional conditions, stress, exercise, pets, animals, and so on. Pets, seasonal uh, inflammations. Some drugs are used therapeutic objectives for or anti-asthmatic drugs. Two strategies to relieve acute episodes by bronchodilators, quick relief medications, and the second strategy is to reduce the frequency of attacks or frequency of episodes. Anti-inflammatory drugs, prophylactic, and so on. Anti-asthmatic drugs, quick relief, bronchodilators. So beta 2 agonistic drugs are used as also antimuscarinics or atropine-like drugs or atropine substituents are used as antibiotics and so on. So anti-inflammatory drugs also can be used uh, as control medicators or control medications and prophylactic therapy, mast cell stabilizers, leukotrienes, corticosteroids, long-acting beta-2 agonists. These are the groups of drugs used for or as antiasthmatics. So sympathomimetic drugs, beta-2 adrenergic receptor agonistic drugs, direct stimulation of beta-2 lead to stimulation of adenyl cyclase, as you know from your biochemistry and physiological knowledge, increase in cyclic AMP. So this will lead to bronchodilation as simply as that. So classification of beta-2 agonistic drugs. Beta-2 agonistic drugs are classified into non-selective and selective. Non-selective like epinephrine or adrenaline. It is non-selective. It acts on both alpha and beta. Beta 2. It acts on both alpha and beta adrenergic receptors. Isoprenaline also it acts on beta 1 on cardiac muscles and on beta 2 on bronchioles. Selective beta 2 agonistic drugs also are subdivided into short-acting and long-acting. Salbutamol, terbutaline, salmeterol, formoterol, and so on. So, epinephrine is non-selective, potent bronchodilator used by inhalation, can be used subcutaneously, but it is not effective orally of short duration of action. These are the main disadvantages of epinephrine. Has short duration of action, drug of choice for acute or anaphylactic shock, hypersensitivity reactions. It is the first choice. Adverse drug reactions of epinephrine, not effective orally, hyperglycemia, cardiovascular, adverse drug reactions, tachycardia, arrhythmia, tremors, headache, and so on. Skeletal muscle tremors, yes, not suitable for asthmatic patient with hypertension or heart failure due to its inotropic effect. Contraindication in cardiovascular disease and diabetic. Selective beta-2 agonistic drugs, first choice for acute attack of asthma, are mainly given by inhalation. Uh, can be used as nebulizer, can be given orally or parenterally. Short-acting selective beta-2 agonistic drugs like salbutamol, terbutaline, long-acting ones like salmeterol and formoterol. Budesonide as a corticosteroid to prevent the episodes or as prophylactic. Short-acting beta-2 agonistic drugs, salbutamol, used by inhalation, can be used subcutaneously, intravenously. Terbutaline can be used subcutaneously. Salbutamol is used by inhalation or oral or by intravenous sometimes. Terbutaline is used by inhalation, orally and subcutaneous, have rapid onset of action and short duration of action. They are of short duration of action, used as sympathetic or symptomatic treatment for acute episodes of attack of asthma. Adverse drug reaction, tachycardia, tremors, headache, and palpitation. Reduce the frequency of episodes. Long-acting beta-2 agonistic drugs, minimal adverse drug reactions. The advantages of long-acting ones, suitable for asthmatic patient with hypertension or heart failure. They do not affect cardiac muscles like salbutamol and the others. Disadvantages: skeletal muscle tremors, nervousness, tolerance can be developed also, tachycardia in overdosage due to stimulation on cardiac muscle. Muscarinic agonistic drugs or atropine-like and or atropine substituents like ipratropium and tiotropium. These are used by blocking of muscarinic receptors given as aerosol, um, quaternary derivative of atropine. It is a quaternary derivative, or they are quaternary derivatives of atropine. Do not diffuse to blood into blood. That means they have no systemic activities. They give a localized effect. So ipratropium is used by inhalation, 20 microgram per puff. Delayed onset of action, long duration of action of tiotropium. Uh, Ipratropium relatively has shorter duration of action, 3 to 5 hours, while tiotropium can reach 24 hours. Muscarinic agonists or anti-muscarinic drugs or atropine substituents that are used. What are the pharmacological actions? They are short duration of action or short-acting bronchodilators, inhibit bronchoconstriction and mucus secretion, less effective than selective beta-2 agonistic drug. No, they have no anti-inflammatory activities. As you know that atropine itself is a bronchodilator, but it is not used clinically for asthma because it increases the viscosity of mucus. So these drugs are uh, reduce bronchoconstriction and reduction of mucus instead of atropine. So they are known as atropine substituent. This was discussed in pharmacology of parasympatholytic drugs, antimuscarinic drugs, in the previous lectures. Main choice of obstructive, chronic obstructive pulmonary disease, COPD. Methylxanthines, as you know that they are of plant origin. They are present as alkaloids in coffee and tea plants. Theophylline, aminophylline, and theobromine. Theobromine is mainly diuretic. So these are the components or alkaloid components of tea and coffee plant. Mechanism of action, as you know that phosphodiesterase inhibitors, so they increase cyclic AMP. This will lead to bronchodilation or muscle relaxation. Act on adenosine receptors, adenosine receptor antagonist. They increase diaphragmatic contractions, so lead to stabilization also of mast cells. Pharmacological action, bronchial muscle relaxants, increase contraction of the diaphragm to improve ventilation. So this will lead to improvement of ventilation. On cardiovascular system, they are inotropics, increasing heart rate and force of contraction. Inotropic and chronotropic effect increase gastric secretion, so hyperacidity can be developed. As you know that xanthines can cause hypersecretion of gastric secretions. So tea and coffee increasing these secretions on GIT. Also on kidneys, they increase renal blood flow, and they have diuretic effects, some diuretic effects, especially theobromine. All of these are with weak diuretic effect. Also CNS stimulation, so they can stimulate respiratory center. They are respiratory stimulants. They are stimulants. Metabolized in liver by cytochrome enzymes, has many drug interactions. So enzyme inducers, liver microsomal enzyme inducers as phenobarbital and rifampicin can enhance the metabolism of xanthines. So this is drug-drug interaction, pharmacokinetic drug-drug interaction. A drug affects the pharmacokinetic or the metabolism of another drug. So xanthine derivatives are affected in their metabolism by liver macrosomal enzyme inducers. So they induce the metabolism and reducing plasma concentration. So the dose must be readjusted or recalculated when they are used with phenobarbital or rifampicin or other liver microsomal enzyme inducers. Also, liver microsomal enzyme inhibitors like erythromycin or other macrolides can inhibit the metabolism of xanthine derivatives. So this will lead to delaying of the metabolism and then consequently increase in plasma concentration, which may lead to toxicity. So the dose is must be adjusted or readjusted or recalculated. Readjustment or recalculation of the dose is needed when they are used with liver macrosomal enzyme inhibitors like uh, macrolide antibacterials. The ancine derivatives also second line for asthma, especially thiophyllin, and also for status asthmaticus. Aminophylline can be given as slow infusion. Aminophylline in IV fluid slowly can be given to prevent, must be given slowly to prevent cardiac arrest. When they are given a rapid infusion, so cardiac arrest can occur. What are the adverse drug reactions? Low therapeutic index, that means they are toxic, they are affecting cardiac functions, GIT functions, nausea and vomiting, and increase in secretions, GIT secretions, also CNS, tremors, nervousness, insomnia, convulsions. All of these are the adverse drug reactions or disadvantages of the unseen derivatives, aminophylline and thiophylline. Also called anti-inflammatory, glucocorticoids. Glucocorticoids are one of the lines of therapy as anti-inflammatories, leukotriene antagonists like montelukast, mast cell stabilizers like ketotifen and sodium chromoglycate. Also anti-IgG monoclonal antibodies omalizumab, sorry, omalizumab. These are anti-omalizumab. Leukotriene antagonist, montelukast, FDA approved for chronic asthma, also for prophylactic effect or prophylactic use, prevention of exercise-induced bronchoconstriction. These are the clinical uses of montelukast. Used also for asthma with or for allergic rhinitis, sinusitis, and systemic vasculitis, and increased eosinophil count. These are the clinical uses of montelukast. Also, has many adverse drug reactions: headache, gastrointestinal upset, myalgia or muscle pain, dry mouth, need monitoring for full blood count, watch for vasculitis, peripheral neuropathy, increased cardiac and respiratory symptoms. Glucocorticoids, mechanism of action, as you know that they act by inhibition of phospholipase 2 or COX-2 pathway, so reduction of prostaglandins and leukotrienes, increased number of inflammatory responses in the airway, mast cell stabilization, reduction of histamine release. All of these are caused by due to phospholipase 2 pathway inhibition. Also inhibition of antigen antibody reactions. Pharmacological effects: anti-inflammatory, immunosuppressant effect of glucocorticoids, metabolic effects, hyperglycemia, increasing protein uh, catabolism, that means reduction of protein anabolism, that means inhibition of protein synthesis, also stimulation of lipolysis, and on glucose, on carbohydrates, they have anti-insulin activities leading to hyperglycemia. Mineralocorticoid, also they have mineralocorticoid effects, sodium and water retention due to their or aldosterone as mineralocorticoid secreted sensitized in adrenal medulla. Sorry, adrenal cortex. Corticosteroids are secreted and sensitized and secreted in adrenal cortex, so they are known as cortisone related to cortex. Hyperglycemia, hypoglycemia, they are non-selectively, they can cause excretion of potassium and retention of sodium. So hypokalemia and hypertension can be developed. Hypertension due to uh, salt and water retention, hypokalemia due to excretion of potassium. That means this is known as mineralocorticoid. Pharmacological actions also, glucocorticoids, they have behavioral changes, mental retardation, reduction of calcium deposition on bones, and so on. So they have many serious adverse drug reactions or pharmacological. They are toxic, especially on chronic use, so they must be used under precaution. Route of administration: by inhalation, like budesonide, fluticasone, beclomethasone. They are used by inhalation. Budesonide is combined with formoterol, as we mentioned before. Budesonide plus formoterol is used for prophylactic or to reduce the episodes of bronchial asthma episodes. That means it is used prophylactically. Orally also, prednisolone can be used. Methyl prednisolone can be used by inhalation, by injection. Hydrocortisone can be given 200 to 600 milligrams, and also dexamethasone can be given by injection to control the emergency cases. Injectable ones are used to control in cases of emergency. Also, they are not bronchodilators, so they are COX-2 inhibitors. reduce bronchial inflammation, reduce bronchial hyperreactivity to stimuli. Yes, have delayed action on the onset of action, have delayed onset of action, maximum effect up to 12 hours. 12 hours and not 12 months. Effective in allergic cases, antigen antibody action, and so on. Hydrocortisone can be given by intravenous and it is a drug of choice for status asthmaticus. Inhaled corticosteroids also for adults, and so they are used. Also, glucocorticoid are other uses. What are the other uses? They have many uses in antigen antibody reaction, in some allergic condition, ophthalmic condition, autoimmune diseases as immunosuppressants, in some anti-cancer, with some anti-cancer as adjuvants for prevention of nausea and vomiting, and to correct immune uh, disorders. So they are combined with anti-cancers. Also, as we mentioned, antiemetics in cancer chemotherapy as adverse drug reactions, adrenal suppression, so they may lead to uh, Cushing, adrenal suppression, adrenocortical insufficiency. They lead to Addison's disease. They are used for treatment of Addison disease. So adrenocortical insufficiency can be developed. Growth of retardation, also retardation of growth in children, osteoporosis, fluid retention, heart failure, glaucoma, cataract, and so on. Adverse drug reactions also including oropharyngeal candidiasis thrush due to disturbance in immune system, dysphonia, voice disturbance, hoarseness. Cough preparations, as you mentioned, as you know, some cough suppressants or antitussive drugs, they are used, not used for productive cough. They are used for dry cough, like dextromethorphan, DM. This is known, and some people abusing it. DM, dextromethorphan. This component of, or it is a narcotic or morphine-like drug, so it can also uh, codeine also can be used because they block central cuff center. They block cuff center, so this will lead to antitussive effect or productive cough suppression. So here we use drugs known as expectorants and mucolytics. What are the expectorants? Sometimes we use ammonium chloride, guaifenesin, APK syrup or APK syrup, and ammonium salts. Ammonium salts are used. They are expectorants. Some of them also, some of cup preparations known as mucolytic drugs that can cause lysis of mucus. They reduce the viscosity of mucus, like acetyl cysteine, methyl cysteine, bromohexene, all of them are used. So dextromethorphan is used as we mentioned, as cough suppressant, has central action on cough center, direct action on cough center on in medulla. It is action or it is addictive property can be blocked by naloxone. Naloxone to block analgesic effect of. It is structurally related to morphine, but has no or little analgesic property. But in high dose, it can give addiction. It can cause addiction. Respiratory failure sometimes may develop due to the use of dextromethorphan, especially in high doses. Some people addicts for this drug or abusing this drug, dextromethorphan DM. Also, dextromethorphan and codeine. Codeine is metabolized in liver, but dextromethorphan has um, this character is not obvious in dextromethorphan. Also, cup preparations, as we mentioned, mucolytics and expectorants, acetylcysteine, ambroxol, carbocysteine. Respiratory tract infections. So, infectious diseases either caused by typical bacteria or atypical bacteria or viral infection or tuberculosis, which is acid-fast bacilli. Typical bacterial infection like examples like gram-positive bacteria, Streptococcus pneumoniae, Streptococcus pyogenes, and so on. Can cause bronchitis, can cause pneumonia, otitis media. Upper and lower respiratory tract can be infected by gram-positive microorganisms. Gram-negative examples for gram-negative: Haemophilus influenza, Moraxella, Catarrhalis, Klebsiella, pneumonia, and so on. So many gram-negative microorganisms or pathogens are uh, infecting or usually infecting respiratory tract. Treatment: penicillins. Various types of penicillins can be used. Second line or third line cephalosporins. Sometimes quinolones are used in combination or alone for treatment of some respiratory tract. The antibiotic of streptomyces erythraeus. Anti-tuberculous drugs, in brief, that pulmonary tuberculosis, uh, in the epidemiology, it is considered, or it compose about 85% of tuberculosis or tuberculous cases caused by Mycobacterium tuberculosis, uh, which is acid-fast bacilli. That means it has a specific uh, structure in its cell wall, not stained by gram stains, not respond to gram stains. Treatment: two phases. The first 2 months for drugs are given. 2 months, this is known as initial phase or comprehensive phase. So isoniazid, rifampicin, pyrazinamide, and ethambutol. Now this is the treatment for continue for 2 months, for drugs for 2 months. And then another phase, continuation phase, two drugs for 4 months. The total will become 6 months. 6 months of therapy. This is the duration of therapy, 6 months. 2 months with four drugs, 4 months with two drugs, INH and or isonicotinic acid or isoniazid plus rifampicin. As you know that isoniazid is isonicotinic acid hydrazide, also abbreviated as INH. It is a cornerstone of treatment of tuberculosis. No regime for treatment of tuberculosis excluding INH or isoniazid. Retreatment or uh, retreatment occur in three cases: defaulter or patient who default or discontinue the treatment, relapse case, patient completing the treatment and then relapse occur, and multi-drug resistant. Multi-drug resistant can be defined as that the sputum is still positive until the beginning of the fifth month of treatment. So this is multi-drug resistant. Multi-drug resistance, MDR. So streptomycin here can be added to the four drugs in the initial stage or initial phase. Second line antituberculous for MDR, ciprofloxacin, levofloxacin, one of the quinolones, gatifloxacin, moxifloxacin, one of them or two of them can be added to cycloserine, ethionamide, or carbamazepine, and streptomycin, and sometimes amikacin. These are the drugs used as second line. Viral respiratory tract infections, usually treatment is symptomatic. Use cool mist vapors or vaporizers. take plenty of water or extra water. Antihistaminic drugs can be used, especially topical ones, decongestants, also behavior. For adenovirus, pseudovirus, and foscarnet are used. For influenza, these are examples for antivirals. Antiviral drugs, influenza virus, oseltamivir, and zanamivir. Amantadine is used for Haemophilus or influenza virus, and also it is anti-Parkinsonism. It is dopaminergic agonistic drug used also for treatment of Parkinsonism. Besides, it is used for influenza virus, amantadine. Also, respiratory syncytial uh, inhaled ribavirin and ribavirin. These are antiviral drugs usually for airborne poisons. What about airborne poisons? Airborne poisons also the poisons that are transmitted through air, so they affect respiratory tract, so they are considered as emergency cases for respiratory diseases. Carbon monoxide toxicity, chlorine toxicity, gases, and some volatile liquids, gases, ozone gas, cyanide toxicity, insecticides, and organophosphorus compounds. This were being discussed in pharmacology of parasympathetic, or they are parasympathomimic cholinesterase inhibitors. We talk about this in past lectures, in the previous lectures. Benzene and kerosene toxicity and other organic solvents, thinners, so on. Carbon monoxide toxicity. For each poison, it is better you have to know source of toxicity, signs and symptoms of treatment, signs and symptoms of toxicity, and the lines of treatment or management. So, what are the sources of carbon monoxide toxicity? Fires in closed area. When we block the doors and the windows and put a fire will consume oxygen producing carbon monoxide. So this is one of the sources. Exhaust of machines, brick lines in Sudan, they are commonly used for production of brick. الطوب، كمائن الطوب مصدر من مصادر التسمم به. أول أكسيد الكربون مع الدخان وغيره. exhaust. What are the main signs and symptoms? Cyanosis, purple coloration due to formation of carboxyhemoglobin, as you know, which is violet in color or bluish in color. Cerebral edema, convulsions. The lines of treatment: oxygenation, mannitol to control cerebral edema, diazepam to control convulsions are the main lines of treatment of carbon monoxide toxicity. Chlorine toxicity. Chlorine, as you know, it is a yellowish gas, irritant for respiratory tract, source of toxicity. It is used for water disinfection, and also it is used as detergent and bleaching of clothes, مبيضات, منظفات, detergents. So some people can use it accidentally or sometimes suicidal tendency. Signs and symptoms: irritation of respiratory mucosa, coughing, sometimes bloody sputum, inflammation. Lines of treatment: oxygen, anti-inflammatory drugs, and to control infections. Ozone toxicity, as you know that ozone is a bluish gas, blue in color, with fish odor present around the atmosphere to absorb ultraviolet or harmful rays in the ground. So the source of toxicity: ozone producing devices that are used for water purification. In water purification, they are ozone producing devices. So toxicity can occur for uh, person who work in water purification. Also around the area of high electromagnetic field, petrochemicals, electric transformers. So the area around these stations, uh, oxygen will be converted to ozone around this high electromagnetic field, and also produced by ozone producing devices used for water purification. Irritation also, respiratory mucosa, inflammation, blood sputum, coughing, and the treatment also oxygenation, anti-inflammatory drugs, and toxicity. Cyanide toxicity. What's the source of cyanide toxicity? Cyanide toxicity, exposure to breath of smoking, laundry detergents, suicidal, also industrial exposure. Signs and symptoms: headache, dizziness, breathlessness. Lines for treatment of cyanide toxicity. The antidote is hydroxy hydroxycobalamin. Hydroxycobalamin, when it is injected, so it will take the cyanide ion and convert it to cyanocobalamin. Interact with hydroxycobalamin, interact with cyanide uh, ion, so it can be converted from hydroxycobalamin to cyanocobalamin. Vitamin B12. Other antidotes: sodium nitrite, sodium thiosulfate, sulfur donor. Oxygen is important also of cyanide. Benzene and kerosene toxicity and other organic solvents and thinners. A source of toxicity. They are used as fuel and organic solvents, as thinners to dissolve dyes and some chemical agents. Uh, so toxicity can occur by inhalation or by injection. Abuse also, some people abusing benzene by inhalation, some of them also accidental. Signs and symptoms: CNS depression, pneumonia, locomotor disturbance, arrhythmia, anemia, leukemia, chronic use, involuntary urination. So, what are the lines of treatment? Symptomatic treatment. Gastric lavage is not recommended. So, the vitals may be aspirated and leading to pulmonary damage. So gastric lavage is not used in organic solvents toxicity like benzene and kerosene. No antidote. Kerosene also can be treated by laxative instead of gastric lavage. So we can cause diarrhea for the patient by the use of laxative to eliminate it through the feces. Respiratory stimulant. Some drugs cause respiratory or used as a respiratory stimulant in cases of respiratory depression. Ethamivan, nicotinamide, atropine itself, cerebral cortex stimulants, and so on. So these are respiratory stimulants used in cases of respiratory. Thank you, and see you later in another lecture. Thank you for